All right, let's learn about transcutaneous pacing. When would you need this? Well, you would need it whenever you have an unstable bradycardic patient. As soon as you identify that your patient is unstable and bradycardic, you must start pacing. You should not try atropine or try epi or try dopamine. Those are for not unstable yet patients. You should not mess around with an IV or oxygen or CPAP or neb treatments. That can all happen once you've got the pacing going, but you must start pacing right away. So how do you pace? Well, there's several steps. You hook it up, you start it up, set the rate, match your current to the rate quickly. Then you look, listen, and feel for capture and make adjustments as needed. We'll go through each of these steps. How do you hook it up? Well, you need your pacer pads on. Those can be anterior, posterior, that's fine. That's my preference, but that doesn't matter. You can also use your standard placement that you would for defib, called the sternum apex lateral, but it's the same position you would normally put them in for defib. Either of those is fine. There's not a lot of evidence that one's better than the other. You must also have the limb leads on for most monitors. So again, you need to know your monitor, know your equipment, and understand what is going on with this particular model that you have. But for most of the time, you need to have limb leads on so that the machine can sense the EKG through one set of wires and send the pacing impulse through the other. Some of the newer ones, I'm told, or at least one new version at this point, doesn't have to have that. But for the most part, get your limb leads on quickly. Turn your pacer button on, or on an older model like a Zoll E series, you have like a 3-position selector switch where you turn a dial to activate the pacer. Know your machine. Also turn up the volume on the heart rate beeper. I know it's annoying, but we need it for now because we're going to look, listen, and feel for pacing capture, and so you're going to want to have the volume turned up. What do you set the rate at? Well, 70 is fine, and most of the time when you're testing at the registry or ACLS, they say 70 or 80, that's fine. 60 makes sense to us for a field setting, but we don't want you to get in trouble when you're testing with somebody. 60 makes sense to us because, you know, we wouldn't be pacing a patient at 60. Most of them don't have perfusion issues due to a heart rate of 60, and so we just rather use that lower rate, which will give us lower myocardial oxygen demand. So if you're going in a testing mode, just set it to 70. And then quickly match the rate to the current. Don't start real slow and hit the button and look for capture, and hit the button to raise the current and look for capture, and go up really slow. That's silly, and we don't like silliness. So match the rate, to match the current to the rate very quickly. Get up to 60 or 70 or 80 or whatever you set the rate at, and let's get capture, or let's at least get close to the capture threshold. Different patients will capture at different energy levels. You have no way of knowing ahead of time, but for the most part, you'll be in good shape if you get quickly up to where you set your rate, and then you may have to go up a little bit more from that. When you assess for capture, we want you to look at the EKG screen, see if your pacer spike is making the QRS. We want you to listen. You should hear beeping that's at the rate that you set, not the rate where they were when you started to pace them. So if you're confused by what you're seeing on the screen, then listen, and you can hear capture just the same as you can see it. Then you need to feel for a femoral pulse. So we can have electrical capture that you can see and hear, but if it's not making mechanical capture, if you don't have a femoral pulse, then you haven't really accomplished anything. It'd be pretty silly to check the radial pulse because radial pulse might not be there because of hypotension, not lack of capture. And so really you wouldn't have an unstable patient with a good radial pulse. And the carotid may be hard for you to feel because as you are pacing the patient, there's muscle twitching in the chest that may make it hard for you to feel the carotid. So look for the pacer spike making the QRS. Listen for the rate to be where you set it, not where they were initially, and then feel for that femoral pulse. Once you've got capture, we'd like to use the lowest amount of current needed to keep capture. So once you have capture, according to many sources, you should adjust down on your current until you just lose capture, then go back up real quick, and then add about a safety factor of about 10 milliamps or so. just so you're not sitting there teetering on the brink of capture, and you may have it or you may lose it. And so I personally am concerned about losing capture in the first place, but technically by the rules, and we should teach you technically by the rules, once you have capture, then you should adjust down until you lose it and then get back up to get it and get you a little bit of a safety factor there so that you use the least amount of current needed to keep capture. Next thing is don't keep peaking at the rhythm. It doesn't matter what the rhythm is. The pacer will go into standby mode. It's a demand pacer. So when the patient's heart rate gets higher than the rate you set, the pacer will stop pacing. When the patient's heart rate gets lower than the rate you set, the pacer will start pacing again. I'll say it again. As long as the patient's heart rate is above what you set as the rate, the pacer's not pacing. It's in standby mode. It's waiting for that patient's heart rate to drop. Then it will start up again. So if you really want to know what the EKG is, well, wait. Just wait. Quit. Don't peak. Don't keep hitting the pause button and trying to see what that underlying rhythm is. It doesn't make any difference. So, kind of repeating, we're going to use transcutaneous pacing whenever and as soon as we have an unstable bradycardic patient. We're not going to mess around with atropine, epidope, and all that. Those are for not unstable yet patients. The unstable patient gets paced, and we're going to start pacing before we do anything else. So, what about sedation? Well, I don't want to be paced. It seems like it could be very unpleasant. And so I would like some sedation if you're going to pace me for a long period of time, I think. But when I'm really unstable and you need to start pacing me, I'm also too unstable for sedation. So if you really feel like you've got to sedate this patient, then think again about if they're unstable enough to even need to be paced in the first place. Now, once you start pacing them, they may perk up after a while, and then maybe you want to do some sedation. Maybe they want some, maybe they don't want some. If it's not bothering the patient, then it shouldn't be bothering you. So sedation is something to think about after pacing has worked. We have capture, a couple minutes have gone by, and hemodynamics are better, and then it would be safe enough for you to sedate. And midazolam, Versed, is an excellent choice for sedation in this place. The amnesic effect from that is wonderful, so they don't even remember this. Same stuff for analgesia. It's almost exactly the same slide. All I changed was the word analgesia plugged in here instead of sedation, and I changed, put fentanyl in here instead of midazolam. It's the same deal. I don't want to be paced. It seems unpleasant. I want to be sedated. I want to have pain control, but I'm too sick for that before you start pacing me. After you're pacing me, maybe it makes some sense. So overall, we're going to pace as soon as we find an unstable bradycardic patient. We're not going to mess around with anything else. We're going to get the pacer pads on, turn the pacer on, set the rate to 60 or 70 or 80, and then match the current to that and see if we have pacing. Look, listen, and feel. See if we have capture. See if we have capture. If we don't have capture, we're going to go up some more on the current. If we do have capture, we're going to back down until we lose it, get back to where we get it, and then add a bit of a safety factor, another 10 milliamps on the current. And we're going to go from there. Then, after they've perked up and are feeling better, then we can think about sedation and analgesia. Pacing's simple. Just don't let it get you all distracted and messing around with other things, and don't be afraid to do it. Your unstable patient, unstable bradycardic patient needs it.